Guru, let me ask you, of course, EV Pembro is the preferred standard of care. Can you describe which patients you may not use EV Pembro, if any, in your practice?
Yeah, I think that EV Pembro is clearly the favorite first-line regimen based on the data. I think that one group in which I have been considering gemcitabine-nivolumab is the group with lymph node-only disease based on the data we showed at ASCO last year, in which the CRs, as you know, are highly durable. The median duration of CR with gemcitabine-nivo was around 3 years. And if you have lymph node-only disease, it's even more durable. So that's a group I would consider it, but I was actually also impressed by the EV Pembro duration of CR, which was at an update at GU ASCO this year, in which the median duration of response was around 2 years overall, with the duration of CR around 75% crossed 2 years. So it's looking good. So maybe it's going to also look very good. But I still don't see that kind of differential between lymph node only disease and visceral disease with EV Pembro as I saw with gemcitabine-nivo. So I do consider gemcitabine-nivo in the lymph node only disease patients.
Got you. Thanks, Guru. And congrats on your work on SICMEN and on one trial that you pointed out too. It's a very important study. And, it was presented at the same plenary session at ESMO 2023. And, everybody, of course, got impressed with EV Pembro. But I think it's, if we didn't have EV Pembro, I think gemcitabine would have got even more attention. May I ask you, Guru, any, let's say, medical comorbidity or any patient profile, frailty parameter that you will be more worried about EV, even using a lower dose to start with, or not to give EV? Again, we all acknowledge that's a strongly preferred regimen.
Yes, EV Pembro, just to recall, the EV 302 trial had very few patients who were PS2. Under 5% of patients were PS2. If you had both poor renal function and PS2, you were not allowed on the trial. And so you do have to select patients carefully for EV Pembro. And also in patients who are frail and have both PS2 and poor renal function or other comorbidities, I think that the Javelin paradigm would continue to play a role in such patients, where I would use Gem Carbo. My favorite regimen in patients like that is split doses Gem if possible, followed by maintenance avelumab. And the Pembro alone paradigm as monotherapy in the first line setting, I have used it very, very sparingly, um, mostly in PDL1 high patients, although it's approved in all comers platinum ineligible, just because of the high PDS best response rate in some of these patients, which you don't want that to happen in the frail, sicker patients.
Thanks, Guru. Great discussion. And Christopher, let me ask you, the urologist in our tumor board today, how common is a scenario of having a patient with lymph node only disease? Back to Guru's example, pelvic, maybe retroperitoneal. That's it, of course, a big distinction between the two. But if this patient has a great clinical response on imaging and clinically on Pembro EV, would you consider doing consolidation, radical cystectomy in that patient? And in which scenarios would you entertain that thought?
Yeah, so I think it's a great idea and a great question. I think we're going to circle back to iterations of this question later on, it looks like. But the real question, I think, comes around to as systemic therapy gets better and we can clear low volume metastatic disease, how does that change our local treatment paradigm? And can we think about consolidative therapy? So surgery is clearly one component. We can also think about radiation-based consolidation. And I think it's a big picture question of consolidate or not consolidate. And then once you're thinking about consolidation, then you can weigh pros and cons of the different modalities. So I guess the first question is, do you think that there is, a good distant response? And that's the clear, initial distinguisher. Then the question is, can you provide additional clinical benefit to the patient with surgical consolidation? And so, we have done cystectomies, pelvic lymph node dissections, including RPL&Ds up to the level like the renal hilum. Is that common? It's definitely not common. It's a very sort of unique, usually patient profile. Typically, it's a younger patient. It's a patient who's had a great systemic response. To be honest, I have done it in the context of older perioperative kind of paradigms, cytotoxic paradigms. I haven't done it in an IO-based systemic environment to date. I think, particularly as we think about EVP in the peri-op setting, the question of do you need to consolidate at all comes up, and that's one extreme, and then the other extreme is, can we consolidate even more patients because we've cleared low volume micrometastatic disease? And so I feel like we can move in both directions, where great systemic therapy opens up local consolidation for a subset of patients who never would have been considered for it before, and yet conversely, great systemic therapy maybe means the value of local therapy is less critical, and we can get away with better bladder sparing with a stronger systemic backbone. And so I think as it evolves, we're going to see more nuance there and more patient-centered treatment decision making, as opposed to the standard recipe that applies to all.
Great discussion. Thank you, Christopher. Before I go to Matt, Betsy, let me ask you on that point. I know you have done a lot of great work in that field of bladder preservation. Any thoughts on that scenario? Does this come up in your tumor boards, with, let's say, pelvic confined, lymph node disease and potential consolidation with either radiation or surgery, or on great response on EV Pembro?
Yeah, thanks. I'll say Matt has a lot of experience with this too, so I'm glad he's up next to comment on this. This comes up at tumor board all the time. I think for locally advanced unresectable disease, we start with EVP because it has the highest response rate and deep responses. I just go back to what Chris said, that I don't think we know if consolidation gets us anywhere after one of those complete response events, right? We know some of these can be durable. We saw that in EV302. These are patients who would be included in EV302. And so I think we kind of hand-wring about it a little bit as to whether we're helping at all with the consolidation. But we do, sort of say, you might have a really good long-term response. This might be, all you need. But I don't know. I'd be curious to hear what Matt thinks.
Great discussion. Matt, what do you think? You have done so much work, the Hoosier trial you led. What do you think on this scenario?
I agree with Chris's comment that I don't think it's necessarily counterintuitive to think about escalation and de-escalation with our newer therapies at the same time. There are patients who aren't curable before we initiate systemic therapy who are probably curable with a great response in surgical consolidation. Alternatively, there are patients who have clinically localized disease who might get away with TUR plus systemic therapy alone. Our challenge is determining who those patients are, but all of us have those patients in our practice. I have patients in my practice I treated 10, 15 years ago who had clinical node positive disease, got systemic therapy and surgical consolidation, and are alive without evidence of recurrence off treatment 10 years later. So those patients are functionally cured. Would they have been functionally cured? Would they have been cured without the surgery? I don't know, but I know they're cured with the surgery. So, I think a lot of these instances where we don't have randomized data, we know what can be accomplished. We don't necessarily know what should be accomplished in any individual patient with the treatment approaches that we have available. And that's where we need to refine.
Excellent points, Matt. And as you said, what can be done doesn't mean we know why it's happening and what is driving that. So it's a great insight.